Earlier we had a discussion on benign breast disease. We know that we had many conditions we discussed. I also told that it is a differential diagnosis for carcinoma breast. Today in this session we will discuss exclusively about breast carcinoma because it is very important. It is a condition which needs a very specified management. So we will discuss everything about the carcinoma breast in detail so that we will have the idea about that, and it is a long case kept in the exam, and also it is a long question, and many short notes will be asked like inflammatory carcinoma of the breast and management of early breast cancer, then pathology of the breast cancer, TNM staging, all those things will be asked in the classification. They will ask ductal carcinoma in situ also will be asked as a short note. So many short notes also will be asked in that's a very important topic, and much more than that, it's a very common condition which we come across in surgical practice in regularly. So and also in the exam it is kept as a long case. So you need to know in detail about the carcinoma breast without any mistake actually. So at the end of this session, the students will be able to learn the following: carcinoma breast etiology, pathology, biological behavior features, recurrent carcinoma of the breast, bilateral carcinoma of the breast, TNM staging of the carcinoma breast, molecular subtypes of carcinoma breast, genomic profiles in carcinoma breast. So come back to the carcinoma breast. It's more common in the developed and Western countries. It is less. It used to be less common in Asian countries, maybe 20 years back, and it is becoming more and more common because of the diet and so many other factors. It is more aggressive in African American women, less common in Japan and Taiwan. It is second most common carcinoma in females, and its incidence is 19 to 34%. Median age is between 47 years, between 40 to 50. Do can occur, but do can occur in younger age group, do can occur in elderly with the variable differences, but average between the 40 and 50 years. Carcinoma in one breast increases the risk of developing carcinoma in the opposite by 3 to 4 times. So if somebody has developed carcinoma right breast, operated, treated and cured rather, and maybe after 10 years there is high risk of developing carcinoma on the opposite side. Incidence of bilateral carcinoma is 2%, and it means there are two types of bilateral carcinoma. From one side it is going to the other side. There is actually a metastatic disease. That is not actual bilateral carcinoma is a de novo. Two malignancy, separate malignancy in the two breasts. So differentiated. That incidence is 2%. So it's got its own criteria. Why you said this is, why you are telling it is two separate malignancies in each breast. So that criteria, all those things we will discuss. Bilateral carcinoma as such, a separate entity. That part we will discuss when we go through in every aspect. More common after middle age, but can occur at any age group after 20 years. Can be familial in 2 to 5% of cases. So it may run in the family. Family history is very important in this patient, which I have discussed while discussing the examination, history taking and examination in case of breast lump. So this is a T3 carcinoma. You can see that inner quadrant, again inner quadrant in the left side, right side. Aggressive. It is quite. Its skin is involved. So naturally it is a T4 lesion. Again skin is involved. See that, and may be involved in the deeper plane also, petrous major muscle, maybe chest wall also. So this is the locally advanced carcinoma breast. You see that entire thing is proliferating, so it is almost the entire breast is involved with the, it's a rather advanced malignancy here. You can see that in this also, see that entire breast is involved, ulceration, nodules, probably adherent to the chest wall. So rather very late carcinoma. This is locally. So what are the risk factors to develop such malignancy? One is mutation of tumor suppressor genes in BRCA1, BRCA2. Now BRCA1, BRCA is the breast carcinoma 1 and 2 suppressor genes. This is very specific. B is a breast, BR is the breast, CA is the carcinoma. BRCA1, BRCA2, there are two types, that's why the BRCA, BRCA2. Involved with high risk. Lifelong risk of breast cancer in BRCA1, BRCA2 mutation is 50 to 70%. Very high. BRCA1 is located in the long arm of chromosome 17. This is important, difficult to recollect and remember, but it is important for MCQ purpose. They can ask in MCQ. Whereas BRCA2 is located in the long arm of chromosome 3. BRCA1 is more risk than the BRCA1. BRCA1 is more common in ER negative, high grade. BRCA2 is more common in carcinoma male breast. So, male breast carcinoma, which gene is important, suppressor gene is important, then BRCA2 we have to remember, that is a MCQ question. So, male breast BRCA2, female breast carcinoma commonly BRCA1, maybe overlapping, that is a different thing. BRCA1 is 17, BRCA2 is the 13, 1713. That's a way exactly better to remember. So, so many syndromes are associated with the carcinoma breast. I am mentioning only few because it is not necessary to mug it up. And if you go through any books, so many syndromes are there. Very important syndromes only I will mention so that you will be able to remember and recollect. Lee-Fromm syndrome is an autosomal dominant condition with the breast cancer in 90%, of course, with sarcoma, leukemia, brain and adenocortical tumors. Cowden syndrome is an autosomal dominant, both are autosomal dominant condition with the cutaneous facial lesion, 100% bilateral breast lesion, J. Paul is brain and thyroid tumors. Remember, thyroid tumor, thyroid, colon, ovary, breast. In a breast carcinoma, patient may be having a thyroid carcinoma or may develop thyroid carcinoma later. Patient also may develop a ovarian carcinoma later. Patient also may develop a colonic carcinoma later. So, very much genetically interrelated. So, you have to remember that. So, other system also, especially these four systems, ovary, colon, thyroid. It is often associated with ataxia cholangioplasia, diet low with the phytoestrogen, high alcohol intake, obesity, have high risk. All these things are becoming increasing trend, obesity, high alcohol, phytoestrogen, high alcohol in females. All these things become increasing in trend. That's why increases the incidence of carcinoma breast as such. Nulliparity or only one child, early menarche, late menopause, late first child birth after 35 years, earlier carcinoma in contralateral breast. If patient is developed carcinoma in the one side, 35 or 30, maybe after 20 years, 15-20 years, other side carcinoma breast is likely to develop. That increases the risk. There is enough time to develop the carcinoma on the opposite side. Breastfeeding reduces the risk. Actually, breast not feeding increases the risk. Opposite is also true. Frederick relative is having breast cancer risk is 3 to 5 times more. It's a family tree is important. You should always ask how many sisters she is having patient, how many sisters patient's mother is having, whether anybody is having. Three generation family tree you have to ask for these things. Gynecomastia in males turns into carcinoma but rare. Remember, it's not that common entity to that gynecomastia turns into carcinoma. Carcinoma can occur de novo in males. It's a rare entity, but if when it occurs, it's very, very aggressive. It is more aggressive than compared to the carcinoma female breast. Benign breast diseases like with atypia, hyperplasia and epitheliosis has got higher risk. Already I have discussed this one. I have discussed about the ANDI or fibrosis stenosis. Epitheliosis components are very, very important. Atypia, then hyperplasia. These three components are more than, there's a high chance of turning into malignancy. So this component, when you look at the histological feature, this is very, very important. Which component this diseases are having, which components they are having more. Previous therapeutic radiation, thoracic radiation for anything, maybe lymphoma or any other condition, who are on oral contraceptive pills also their risk but not proved. Hormone replacement therapy for more than 5 years, again they may be. Now this is an entity, specific entity. Radial scar may produce carcinoma. What is a radial scar? Is a very specific entity, not just a scar of the wound. It is a complex, it's a pathological condition actually. It's a complex sclerotic condition of breast with microcyst, epithelial hyperplasia, adenosis, central necrosis with the lesions less than 1 centimeter in size. It mimics carcinoma clinically and mammographically. That is a high risk of turning into malignancy, radial scar. So it is radial scar is not a surgical scar, it's a pathological entity, remember. So that word confuses you people, don't get confused. Prior diagnosis of uterine, ovarian, colonic cancers, I have already told. Presently, carcinoma breast is considered a systemic disease, that's what you have to remember. Halsted concept of spread is a sequential spread. Halsted, long ago, 100 years ago, he has designed radical mastectomy, all those things. The apical lymph node is called as Halsted lymph node. Halsted did extensive work on hernia surgery also. It's a multifocal surgical person, invented so many things and given so much to the surgical system. Even he invented the gloves to wear during surgery. So he thought it is sequential from the breast to the axillary lymph node, axillary into the supraclavicular lymph node, then to the blood. That is what we used to think for long time. Then later it is said that it is a systemic disease, it can bypass lymph node and go, and now it is thought that it is initially sequential, eventually systemic, like that combination of that. So all those different theories are there. Old concept of Halstead, which is sequential breast, lymph node, blood, like that, it is no more considered actually. Breast, axillary node, systemic spread. Fissure comes with early to begin with itself. There is distant blood spread because of micrometastasis. That is what Fischer told, micrometastasis without nodal disease. So without node there may be a spread also, that is possible through the blood. So that is why it is thought, now considered as a systemic disease. Only tumor lesser than 1 centimeter size is sequential. So what Halstead thought is only, what Halstead thought is useful only if primary tumor is less than 1 centimeter, then it will be spreading to the lymph node, then to the blood. Anything more than that, it can spread to the blood directly, bypassing the lymph node. So that is the current concept. They are called micrometastasis without nodal disease. Now, newer Hellman spectrum concept is a new one where disease spreads loco-regionally as well as systemically, which makes it to aim at both loco-regional disease control as well as systemic disease control. So this is a newer combination of that, both loco-regional as well as systemic disease control. So this is a combination of that. So Halstead concept, Fischer concept, Hellman spectrum concept. These are the three concepts which you have to remember when you think about the spread or biological behavior of the carcinoma, how it behaves as far as spread is considered. So risk factor classification is florid hyperplasia, slight to moderate risk florid hyperplasia, solid duct papilloma, obesity, alcohol, HRT, nulliparity, early menarche, late menopause, moderate to high risk, age more than 60 years, ADH, ALH, LCS. LCS is considered as a benign, but it is high risk definitely. Atypical ductal hyperplasia, atypical lobular hyperplasia. D is ductal, H is hyperplasia, A is atypical, L is lobular. History of ductal carcinoma in situ, cancer on one side breast, other side I already told. Very high therapeutic radiation. Family history of breast cancer in 2 first degree relatives. Family history of breast and ovarian cancers I already told. BRCA1, BRCA2. BR is breast, CA is carcinoma. 1 and 2 mutation carrier. CA1 is 17 chromosome, CA2 is 13 chromosome. This is mainly for the male breast. CA1 for the female, or female can have a CA2 breast mutation, carries on the first degree relative with the mutation. So these are the risk factor classification, slight to moderate, moderate to high, very high risk. These are the causes for this classification. Now a pathological classification is ductal carcinoma, lobular carcinoma, based on where it arising from. If it is from the lobules, it is called lobular carcinoma. If it is from the duct, it is called ductal carcinoma. Now in situ ductal carcinoma, non-invasive, does not breach the epithelial basement membrane. If it is within that, then it is called ductal carcinoma in situ. Ductal carcinoma in situ and lobular carcinoma in situ is now taken down. It is considered as a benign entity with high malignant potential. It is older classification. Lobular carcinoma in situ is said to be used to be considered. Now current 18th edition, AGS is the staging system. LCIS is removed. DCS definitely it is there. So it is removed actually. Otherwise, olderly it is called in situ, but it is a highly potentially malignant condition. Now, invasive again say invasive ductal carcinoma is the most common type. It is an MCQ question, which is the most common type of carcinoma breast. You got option DCIS, LCIS, ductal carcinoma, LCIS, invasive ductal carcinoma, invasive lobular carcinoma. So it is commonly multifocal, which is more commonly multifocal. Then invasive lobular carcinoma is more common multifocal. Invasive lobular carcinoma is more commonly multifocal. It can be unilateral, it can be bilateral, already told. Unifocal, multifocal tumor tissue within the same quadrant but multiple foci. So only one single in one quadrant unifocal. 2 in the one quadrant is called multifocal. Many in the different quadrants they are called multicentric. So that is the technical meaning of this classification. So what is to mean ductal carcinoma and lobular carcinoma? In situ, that's not non-invasive. Invasive is ductal carcinoma, invasive lobular carcinoma, unilateral, bilateral. Of course, unifocal, multifocal, multicentric, already told. So invasive ductal carcinoma is the most common type. Remember, adenocarcinoma is the no special type is more common. That's again entity called adenocarcinoma is the no special type. 60% of this will show macroscopic spread to axillary nodes, micro or microscopic spread to the axillary nodes. Adenocarcinoma with no special type, that NOT, no special type. So all these recent classifications which is more common. 60% diseases show micro and microspectral. That's why it is important. A spread commonly to the axillary nodes. Invasive type can be special type or no special type. Again, invasive type, no special type, special type, not otherwise specified, otherwise also called as it, not otherwise specified, or NOS, not otherwise specified invasive type. Special type is 20% common. It may be tubular, miscellaneous, cribriform, medullary, etc., and they carry good prognosis. Now, what is important is no special type, not otherwise specified, NOS, both are same. No special type, not otherwise specified, NOC or NST, they carry poor prognosis. Not otherwise specified to carry poor prognosis, but special type carries good prognosis. So that specification is important. No special type or not otherwise specified, and special type. Special type carries a good prognosis, not otherwise special, specified, not otherwise specified, or no special type, that it carries poor prognosis. So this is the meaning of unifocal. This is the meaning of this diagram clearly shows what is the meaning of multifocal. This is multicentric in different quadrants. That is a different quadrant. So this involves more area. This involves only one quadrant. So difference is, you make out the difference between the technical meaning of the multicentric and multifocal. This diagram clearly shows unifocal, multifocal, multicentric. So classification of primary breast cancer, non-invasive epithelial. Currently is considered benign entity LCS, ductal carcinoma in situ. It may be papillary, solid, cribriform, comedo. Invasive epithelial, invasive nobular, ductal, invasive ductal with not otherwise specified or no special type 70%. This is 70% common. Invasive ductal with not otherwise specified or no special type. Tubular, colloid, medullary variant basal like invasive cribriform, invasive in papillary. Adenoid, cystic, metaplastic, all these different histological types between invasive, non-invasive, and invasive type. Mixed contribution epithelial, phylloid is angiosarcoma, carcinosarcoma. This is the primary breast cancer. I am not telling about the just carcinoma of the breast. Any breast cancer, for sarcoma rarely can occur, carcinosarcoma can occur, phylloid tumor can occur rarely. So these are the different classifications which I just wanted to put forward. So types of carcinoma breast are serous, pathological, old classification, serous, still good, it's easier to understand, only gross, it is basically a gross classification, I can put it like that. Serous word itself is a cartilaginous, tough, 60% common, it is hard, it is again maybe MCQ question, which is the commonest pathological type, serous type. Newer classification, it is the invasive ductal carcinoma, where not otherwise specified, no special type, that is the commonest type, remember. It is hard, whitish or whitish yellow, non-capsulated, irregular with the cartilaginous consistency. It contains malignant cells with the fibrous stroma. It is important. Consistency is cartilaginous. It's very important. Medullary carcinoma is 5%, also called as encephaloid type because of its brain-like consistency. Contains malignant cells with dispersed lymphocytes. Colloid carcinoma, it produces abundant mucin both intra and extracellularly, carrying better prognosis. Atrophic serous carcinoma seen in elderly females. Slow-growing tumor which has got better prognosis. FN is diagnostic or true cut biopsy. Now currently true cut biopsy, not FNAC. FNAC definitely, but a true cut biopsy is the idea currently because it can do a marker, everything. ERP, ERPR, HER2/neu, all those things. Mastectomy or curative brachytherapy using breast molds is the treatment of it is often curable. It's a very good prognosis that atrophic serous type occurs usually elderly female. Just to do mastectomy, that is sufficient. Or otherwise curative radiotherapy, curative brachytherapy can give to this patient. So this is the cut section of serous types. Is that very cartilaginous consistency? Is that very whitish structure is very typical of this. There is no capsule here for malignancy. Look at that. There is no capsule. No capsule here. It is adherent to the breast tissue. All those you can see the section very clearly. This is the typical atrophic serous carcinoma in elderly female. It usually carries a good prognosis. Remember. Now another type is very important, which is a very aggressive. Of short duration, occurs in young individual, mimics the lactation because usually they are lactating or pregnant woman, and there is what is called a lactational carcinoma of the breast, also called the mastitis carcinomatosis because it mimics mastitis also, breast abscess also, in lactating woman. So that is why it is called inflammatory carcinoma, a different terminology which are combined together, inflammatory carcinoma, because that inflammatory and carcinoma, there is no inflammation actually because it mimics the inflammation. This is called as inflammatory carcinoma of the breast, very aggressive. It is a T4D actually, T4D. To all inflammatory carcinomas is T4D, that means stage 3. There is to begin with. There is no stage 1 and 2 for inflammatory carcinoma of the breast. It is also called lactatic carcinoma, metastatic carcinoma is the more aggressive type of carcinoma of breast. Remember, 2% common incidence, common in lactating woman or pregnancy. It is rapidly progressive of shorter duration, diffuse, painful, warm, often involving whole breast tissue with the occurrence of pudgy orange, often extended to skin of the chest wall. It's very progressive tumor, right, involving almost entire breast of all quadrants. This is very, very important. Entire breast is in node. That is very, very important. Eventually, of course, more than 1/3 of skin node of the breast is in node. This is very, very important. How much skin should be in node? Diffuse lymphedema is due to tumor emboli with the dermal lymphatics. So they will have lymphedema, so that pudgy orange is common because of the dermal lymphatics. Underlying local is palpable mass, need not be evident clinically, but everything diffuse it is. So you don't get a clear-cut localized mass there. That is what you would remember. Unlike other carcinomas, serous and other type, visual carcinoma breast, you get a clear-cut mass there. Whereas inflammatory, you won't feel it. Entire breast is swollen. Mammography may not show any finding except skin thickening. That is again a point you would remember. Mammography is inconclusive, remember. Inflammatory carcinoma breast is a clinical diagnosis. More often the clinical diagnosis, finish comes the diagnosis, or you can do a true cut biopsy also. Punch out, which is ideal and better with show undifferentiated cells. What it shows, undifferentiated cells, whatever it is, either a finish, true cut biopsy or punch biopsy, it shows undifferentiated cells. CT chest and abdomen is done. It rapidly metastases to chest wall, bone and lungs. It is always stage 3, minimum stage 3B carcinoma, T4D. There is no stage 2, stage 1. Mimics acute mastitis, but total count is normal. So this is the differential diagnosis which you have to remember always. See that inflammatory carcinoma breast involving in the extensive, the entire breast is involved. Now treat biopsy is the true cut biopsy. Then of course CT chest, CT abdomen, maybe CT brain you have to do metastatic workup. Then treatment is initially external radiotherapy and chemotherapy. Salvage surgery whenever possible, mostly inoperable. It is possible. It has got worst prognosis. So in chemotherapy or radiotherapy and chemotherapy you have to give. It carries worst prognosis. Remember. Entity is not new, but I am telling next entity, Paget disease of the breast. It's a very common question which is asked in MCQ, in theory they will ask, in Viva they will ask, and it's one of the type of the carcinoma breast actually, not a benign, and which involves the nipple and areola, and there is a mass underneath. So that central compartment, central quadrant is involved. So central quadrant involvement, nipple areolar complex is involvement, and there is a mass underneath. So that's a very typical of the Paget disease of the breast. It's a carcinoma breast type actually. It's a superficial manifestation of intraductal carcinoma. The malignancy spreads within the duct up to the skin of the nipple and down to the surface of the breast. So there it starts that area goes deeper plane. Mimics eczema of the nipple and areola. In Paget disease there is a hard nodule just underneath the areola. If this is the areola, this is the nipple, and a mass will be there underneath. And nipple and areola get destructed. The later ulcerates and causes destruction of the nipple. So everything gets destructed actually. Histologically contains large ovoid clear Paget cells with malignant features. It is 2% common, 90% is invasive ductal carcinoma. So incidence is same. Inflammatory carcinoma is same thing, around 2%. This is also 2%. Same incidence is same. 90% is invasive ductal carcinoma, 70% shows mass under the nipple and areola. This is very common. Often they are called as comedocarcinoma, which is a comedocarcinoma type actually. Paget's hyperchromatic cells are located in the retapex of the epidermis containing intracellular mucopolysaccharides and clear halo in cytosol. So it's a very, very typical histological pattern. So histological always you can diagnose the clear halo in the cytosol with the retapex in the epidermis containing intracellular mucopolysaccharides. Breast conservative surgery is difficult here, hence MRM is needed. You can't do conservation of the breast because the nipple area is gone actually. So Paget disease mimics eczema. Paget disease is unilateral, edges are distinct, itching is absent, seen in menopausal woman, vesicles absent, nipple is usually destroyed, underlying lump is usually present and palpable. Eczema is bilateral, edges are indistinct, itching is present, that is absent, occurs during the time of lactation, vesicles present, nipple is usually intact, no underlying lump. So this is a very typical differences between. So this is the typical look of Paget disease of the breast. There is almost ulceration is there, almost nipple is distracted, almost extended to the nipple. Almost areola is distracted, not nipple. Areola is distracted. See the areola is distracted, extending into the nipple. So that is a very typical of the Paget disease, destruction, mainly destruction of the nipple areolar complex. And having discussed about the Paget disease, you should know the difference between eczema and Paget disease. You should know the incidence. You should know what exactly meaning nipple earlobe destruction, ulceration with the hard mass underneath. It's very, very typical of the Paget disease of the breast. It's always malignancy. It's got special Paget cells with hyperchromatic features. So very typical it is. So we can't do the breast conservative surgery. That's why it's very important. You have to do mastectomy in this patient. So having discussed about Paget disease, another important topic is the lobular carcinoma in situ and invasive lobular carcinoma. So this is what it is currently considered under carcinoma breast. This earlier used to be lobular carcinoma in situ. Earlier used to be considered to be malignant part. Now it is considered as a benign, but potentially malignant, precancerous condition, something like that. So current 2018 classification, AJCC classification, they said it is not involved in the AJCC staging system, but it is potentially malignant. But I have put it here as an invasive carcinoma ILC because it is related very much. It originates in terminal duct lobular unit of female breast, only showing its distension and distortion. 12 times more common in white females, predominantly perimenopausal. 12 times more common in white females. I said LC, left lobular carcinoma incidence is 3 to 5% common. Again, almost same. Paget lymphatic carcinoma 2%, little more, 3 to 5%. High chance to predispose to invasive cancer. 35% of lobular carcinoma incidence may develop invasive lobular carcinoma either in the same or contralateral breast. Lobular carcinoma incidence is a marker or predictor of increased risk of invasive breast cancer. So it is a marker or predictor. It has very high chance of turning into malignancy eventually, but not an anatomical precursor. Unlike DCIS. DCIS is anatomical precursor, but this is not a anatomical precursor, but it's a high chance to predispose invasive cancer. Lobular carcinoma is currently considered as a benign entity but having malignant potential. So it is removed from the AJCC 2018 system, I already told, but it's discussed here because it's very closely related, it's got a malignant potential and because of similarity. Now currently it is removed from the carcinoma breast classification because it is considered as a benign entity with the malignant potential. So LCA, that's why it's a lobular carcinoma in situ, invasive lobular carcinoma. This is the malignant always, this is the malignant. Clinically it does not form a lump, it is multifocal and bilateral, it's very, very important. Multifocal and bilateral, it is an incidental pathological entity often. Invasive lobular carcinoma, classical type carries better prognosis, pleomorphic type does not. So occasionally mixed ductal lobular in situ may be seen. So maybe having a ductal also in situ and lobular in situ. Need not be detected by mammography as it does not provoke calcification. So mammography may be normal. So clinically, sonologically, radiologically, breast will be normal many times in this phase. That's what is worried actually. Screening mammogram yearly, MRI, breast observation, tamoxifen or aloxafen in a perineal stage group, bilateral mastectomy done when doubtful. So when doubtful you have to intervene, you can always give tamoxifen or aloxafen in these patients. It will be definitely helpful. ILC or invasive lobular carcinoma has poor prognosis due to bilateral, multifocal nature and difficulty in identifying. Now, invasive lobular carcinoma is always malignancy. It's only lobule, not ductal. Arising from the lobule, not from the duct. So it has got, it is bilateral or multifocal. It carries a poor prognosis because of its bilateral multifocal nature, remember. So having discussed about the invasive lobular carcinoma and lobular carcinoma in situ, it's a benign entity currently not malignant, even though it is discussed here. Remember, it's related, that's why I put there where understood that the difference is there. Now next important thing is duct carcinoma in situ. That's again a short note, remember as a separate entity. I said lobular carcinoma in situ is a benign entity which earlier thought to be malignant. Now it is very, very well proved that it's a benign entity. It is intraductal carcinoma, proliferation of malignant mammary ductal epithelial cells without any invasion into the basement membrane. So basement membrane is intact here. Minor lateral epithelial proliferation is the typical histology, 5 to 20% common, associated with the high expression of CERB2 gene. Associated in 20% of cases, synchronous invasive carcinoma in the duct is seen. That is very, very important you have to remember. 20% of the patients, synchronous invasive carcinoma will be there. Untreated duct carcinoma in situ becomes invasive in 50% of cases. In 50% of cases, it becomes invasive. So naturally, it has not gone to the basement membrane. It will go into the basement membrane eventually. So definitely, it has to go into that definitely eventually. So presence of more than 25% duct carcinoma in situ component in the main invasive tumor, or if duct carcinoma in situ is present elsewhere in the surrounding breast tissue, it is called as extensive in situ component. So definition of extensive in situ component, remember, more than 25% duct carcinoma in situ component, the main invasive tumor, or if duct carcinoma in situ is present elsewhere in the surrounding breast tissue, it is called as extensive in situ component. If it is more than 25% or elsewhere in the place in the breast, it is seen, observed, that is called extensive in situ component. 5% of male breast cancers are duct carcinoma in situ, remember. Nipple discharge and often small swelling are main presentations. Ultrasound assisted FNAC and mammography are the needed investigations. You can do guided true cut biopsy also currently, that is the accepted method, definitely true cut biopsy. It gives a clear idea about the histological nature and all other things. Risk of lymph node spreads in duct carcinoma in situ less than 4%. So axillary dissection is not necessary. Sentinel lymph node biopsy and proceed is the preferred method. So whatever you do, do a treatment for primary one, then for auxiliary thing, you either if lymph nodes are there, do a ultrasound guided FNAC or do a sentinel lymph node biopsy, whatever it is, pick up, and then do the surgery or treatment for that accordingly. So Nottingham prognostic index is used for the duct carcinoma in situ, 0.2 into tumor size centimeter plus lymph node stage plus tumor grade, MPA score less than 3.4, good prognosis with 80% survival, 3.5 to 5.4, moderate prognosis with 40% survival, and more than 5.4, poor prognosis with 15% survival. MPA score may be asked in the theory exam, Viva they may not ask. Theory, if they ask as a duct carcinoma in situ, you have to write. And sometimes MCQ they will ask. Nottingham prognostic index, NPI is used in, and you should remember, it is for duct carcinoma in situ in the breast and not in other entity, other areas. So types of duct carcinoma in situ are solid high grade, commuto with necrosis high grade with increased terms of microinvasion, cribriform papillary low grade, papillary cribriform or low grade, including micropapillary, remember. One nice prognostic index for duct carcinoma. So all these indexes are very difficult to remember, but in theory you have to ask, you can tell. Why they might ask, but mainly it's the theory question. Duct carcinoma in situ. There you can add on to these things. This is the score 1 to the scoring is there. Size in millimeter, more than 15 millimeter, 16 to 14 millimeter, more than 40 millimeter. This is what is worried actually. The scoring system actually. If this is more than clearance margin more than 10 millimeter, 1 to 9 millimeter, less than 1 millimeter. Grade and necrosis not high grade, no necrosis, not high grade necrosis present, high grade necrosis present. So when all these things are there, then it is a worried thing. Age in like more than 61, 60, less than 39 points. Percentage of local recurrence, risk procedure 4 to 6.1% recurrence, low risk. 7 to 9, BCS without RT treatment, 97-98% survival. 7 to 9 points are 20% recurrence, local recurrence. Intermediate, breast carcinoma with RT. Treatment is same. It is without RT, here with RT. This is incident, 70 to 80% of cases. 10 to 12 scoring is very high scoring actually, 50% local recurrence, high grade, it is high risk actually, high risk it is. Total mastectomy with 34 to 51%. Total mastectomy is the treatment of choice in the, if it score is 10 to 12. So it is scored actually, based on this it is scored. Scores are there, 1, 2, 3. Same you have to apply here to get a points and then decide what exactly procedure. It's a very, very important scoring system used in the, it's actually modified scoring system used in the carcinoma breast, remember. Very, very useful, especially in duct carcinoma in situ. So management of duct carcinoma in situ, FNAC confirm the disease, but will not differentiate from the DCIC, IS and invasive carcinoma. That is again problem, it won't differentiate. Mammography, ultrasound breast, MRI, routine metastatic workup, breast conservative surgery with RT, the breast triangle dissection after SLB if positive. We can do breast conservative surgery in these patients with the RT to breast and axillary dissection after sentinel lymph node biopsy. Hormone therapy prevents both local recurrence and development of new primary breast carcinoma. That is very, very useful actually, tamoxifen, hormone therapy, very useful definitely. Now indication for total mastectomy DCIS are positive margin after wide local excision, 2 or more primary tumor, multicentric positive margin, when radiation to breast is not possible, collagen diseases, tumor breast size ratio is not appropriate for conservative surgery. Diffuse microcalcification, family history and DCIS in pregnancy. So all these things are the indication for total mastectomy in DCIS. Positive margin, 2 or more primary, multicentric, this is very, very important. Multifocal, it's okay, that quadrant you can remove. Tumor breast size ratio is not approved for conservative surgery because ratio is the volume, total volume of the breast and tumor size is important. The ratio of the volume of breast ratio is very, very important to have a conservative breast surgery, very important. Family history, that's because it's pregnancy. Now another skin clearing mastectomy may be ideal in such occasion with the intermediate, immediate tram and relative flap. You can call the plastic surgeon for transverse abdominis myocutaneous flap, or you can take latissimus dorsi myocutaneous flap, and you can do a skin pairing mastectomy also, where muscle only can be used as a prosthesis, or to close the bulk, to cover the bulk actually, to cover the defect actually as a bulk, cover the defect as a bulk. So what are the gradings of the carcinoma breast? Externalized LC modified Scar-Bloom-Richardson grading system. Score 1, 2, 3 are there. Nuclear pleomorphism, relatively small uniform nuclei, intermediate pleomorphism nuclei, large pleomorphic nuclei. Now there is very nuclear pleomorphism, mitotic count, tubule formation, less than 10% mitosis in 10 hyperfold, 10 to 20% mitosis, more than 20%. These are the things which indicates that how bad things are. So less number percentage is good actually. If it is more than score 2, score 3, it becomes tubule formation, more than 70% in tubule formation, 20% of cells in tubule formation, less than 10% cells in tubule formation. This is very important. Tubule formation and percentage is very, very important. It decides the grading actually in these patients. So whoever is graded, then you can get whatever the treatment you can eventually plan and decide, or final outcome or further therapy. Grade is remember, this is the grade favorable, unfavorable, depending on the score, depending on this score actually. SBR scoring, so Elston is a modified Scar-Bloom-Richardson grade scoring system. Unfavorable up to 3, grade 1 3 to 5, grade 2 6 to 7, grade 3 8 to 9. So grade 3 like that, it is a grading based on this score. These scores are placed in this table and then decide what exactly is the grade, and depending on that you can plan the treatment or predict the prognosis. Well defined low grade, grade 3, 4, 5, moderate defined intermediate grade, grade 6 and 7, poorly defined grade, high grade, grade 8 and 9. So that is how it is differentiated, well, moderate, poorly. Then accordingly you plan the treatment, accordingly decide whether you want to do a simple lymph node dissection, accordingly decide whether additional further therapy, adjuvant therapy has to be given or not. So what are that is about the grading of the carcinoma breast. I have already discussed in detail. That is usually very useful. This grading is for dust carcinoma in situ. That's why it's put in with the dust carcinoma in situ. Now what are the biological behavior of the carcinoma breast? So 4 things very important. Cutaneous manifestation, spread to the skin and other area, locally and distal area, spread to deeper plane, the lymphatic spread and blood spread. Now pudgy orange is very important due to obstruction of dermal lymphatics, opening of sebaceous glands and hair follicles get buried in the edema, giving rise to orange peeling look. Dimpling of skin due to infiltration of the ligament of the Cooper. I already discussed while discussing about the clinical part. Retraction of the nipple due to infiltration of lactiferous duct. So this is due to lactiferous duct retraction. Ulceration and discharge from the nipple and areola. Skin ulceration and fungation. Cancer encurase, skin over the chest wall, breast is studded with the cancer nodules appearing like an armor coat. Armor coat, entire area skin nodules are there. In the breast, skin over the breast is adherent. Surrounding area also it will be there, like armor coat. Tethering of the skin can occur. So see the ulceration with the pudgy orange. Pudgy orange is there, ulceration is there, cancer encurase, entire areas. See the nodules there. Cancer skin fixation here, because you can see that pudgy orange appearance of skin. See that this is a pudgy orange. Look at that. This is the pudgy orange. Pudgy orange is ulceration. Pudgy orange may be there. Pudgy orange may be there. One more swelling is there. See the cancer encurase. Cancer encurase, ulceration, pudgy orange, extensive skin involvement. So all these things are the different approaches, different features. Skin involvement, skin involvement is carcinoma breast, outer quadrant here. There are auxiliary space is hollow actually, nothing involved. This is ulceration. See that areola, nipple areola complex is involved. One more area. The bridge is here, but one more area is involved. So ulceration, skin involvement, and see that cancer encurase, pudgy orange. Everything is important in the skin. Everything you should suspect and make a point of giving a chance to the patient and have a clinical feature. This is a nodularitis, advanced carcinoma of breast. This ulceration, it is also considered as advanced, locally advanced carcinoma of the breast. So the typical pudgy orange, you can always use magnifying lens to identify that because of the localized lymphedema, hair follicles get buried. It looks like a orange peeling. It's very typical. So spread into the, having discussed about the cutaneous manifestation of the carcinoma breast is a common short note asked. So all these things you have to write, cutaneous skin, other structures, the deeper plane, entire thing you have to ask. So whatever the investigation, whatever I have told, what are the features I have told, you need to remember that is sufficient if they ask. Then cutaneous manifestations of the carcinoma breast is important topic, remember. Should not say I don't know. Spread to deeper deep into the deeper plane into petrous major muscle is confirmed by observing observing the restricted mobility of the swelling while contracting the petrous major muscle. That's very, very important. There is a swelling here, so naturally contract, hold it like that, contract, then confirm contraction is adequate by feeling the stiffness of the anterior axillary fold. Then after pressing that, you check the mobility, whether it is restricted. If it is restricted, then you have to do biochemical analysis also in this patient. In latissimus dorsi muscle extending into the and extending the shoulder against resistance. Into serratus anterior by pushing the wall with hands without flexing the elbow like this. And this is again resistance like this. And petrous major like this. If it is involved, then you have to do other analysis, biochemical and markers, so on. Latissimus dorsi I already told. Into the chest wall, breast will not fall forward when leaning forward, like this. And while raising the arm above the shoulder, breast will not move upwards as it is fixed to the chest wall. See that? These are three things where I have discussed: petrous major, latissimus dorsi, falling forward or raising forward. Chest wall involvement in carcinoma is a typical chest wall involvement carcinoma of the breast. Now lymphatic spread in the carcinoma breast. So skin, deeper plane, then lymphatic spread, then hematogenous spread. Now having discussed about the spread into the skin outside, deeper plane, now we will discuss about the very important spread is lymphatic spread. That is a very, very important deciding factor in thinking about the prognosis, very important, as well as it is also important in planning the treatment. That is why it is important. Lymphatic spread. Lymphatic spread occurs through subaerial or sepious lymphatic plexus, cutaneous lymphatics, intramammary lymphatics, that lymphatic channels. Lymphatic drainage of the breast is predominantly to the axillary. All of you know that 70%, and then internal memory in the medial part through lymphatic permeation. I already shown this surgical anatomy when I discussed of the breast, where are second, third, and fourth intercostal space, pre-sternal, I said, post in the intercostal space, close to the endothoracic fascia. These intermemory nodes are there, and it may inner quadrant may spread to the intermemory nodes. Otherwise, predominantly to the axillary node, and through lymphatic permeation. That's also I told earlier. Usually, from the primary tumor to the axillary node, it goes to the permeation. That means malignant cells proliferate through the lymphatics into the axillary lymph node, and from the axillary lymph node, it to the further levels, maybe supraclavicular lymph node, maybe rotor's lymph node, from the maybe supraclavicular lymph node, it spreads through the lymphatic embolization. That means malignant cells get dislodged and flows in the lymph. And another way is reverse flow that occurs in the like in retrograde spread in the rotor's lymph node, and lateral and posterior group of axillary lymph nodes can get involved by retrograde spread. So permeation up to the first level, axillary lymph node, not the first level, axillary nodes, and embolization up to the supraclavicular lymph node, retrograde to the usually to the rotor's node, sometimes to the lateral and posterior group of lymph nodes. That is what exactly it meant. Mainly axillary node. Interpetal node lies between the petrous major and minor rotor's nodes. Due to retrograde spread, rotor nodes drain into the central and apical nodes. From axillary lymph nodes, spread occurs to supraclavicular nodes by lymphatic embolization. I have already told. This is the retrograde spread. This is the permeation. So permeation, retrograde spread, embolization. Through dermal lymphatics, it may spread to opposite breast or to opposite axillary lymph node. So it can go to the how exactly it goes to the opposite side. Spread may occur into internal memory lymph nodes on the same side, and then to the mediastinal nodes, and contralateral intermemory nodes, lymph nodes can get involved by retrograde spread, and so opposite axillary nodes. So opposite axillary nodes can get involved. If the right side growth is there to the dermal lymphatics, it can go to the opposite axillary lymph node, or it may go to the internal memory lymph nodes here. From there it goes to the opposite internal memory nodes. From there it may go to the opposite axilla. through maybe through the retrograde spread. So that is why that opposite axillary lymph nodes are by two methods it may get involved. See that it's a primary carcinoma of the breast with the axillary lymph nodes. See the axillary lymph nodes involved here. It's a growth here. So exactly spread here. It's the anterior group of lymph nodes, remember. So fixed enlarged axillary nodes can cause lymphedema due to lymphatic block. So it causes the lymphedema because of lymphatic block. Venous thrombosis, venous edema due to venous block. It may, lymph nodes can compress over the vein and venous edema occurs. Then there will be bluish discoloration, edema, mainly edema in the arm. Whereas lymphedema, infiltration of the tumor itself is there, that's why lymph doesn't flow. So there will be mainly distal part in the hand and forearm, then arm, like that. So venous edema, it's a bluish color, it's pitting. Lymphedema initially may be pitting, after that it may not be pitting, but mainly distal, then proximal. Severe excruciating pain along the distribution of the median and ulnar nerve in this area, rare in radial nerve, with the often significant sensor and motor deficits due to the tumor infiltration of the cords of the brachial plexus, medial cord of the brachial and often lateral, mainly middle cord of the brachial plexus, often lateral cord. So they will have severe excruciating pain with sometimes neurological deficit in the upper limb. So that is what you have to remember because of the enlarged lymph node. So all these things can occur: lymphedema, venous thrombosis, pain. So carcinoma breast right side causing extensive edema. See that lymphedema in right upper limb. So causes of lymphatic block in carcinoma breast: enormous fixation of the axillary lymph node level 1 to 3. After levels 1 to 3, dissection also, after surgery also, after radiotherapy also. Inoperable fixed nodes in the axilla. Recurrent axillary disease may be associated with the cancer incurage, secondary infection. All these things are the causes why lymphatic block can occur in carcinoma breast. What is the treatment? Elevation of the limb, stockings of the upper limb, pneumatic compression of the upper limb. Drugs like diuretics and benzopyral, the less effect actually, said to be quite useful, but it is only temporary, not less effect. Temporary it will reduce, but because the cause is there, some specific cause is there, it will recur actually. So effects of lymphatic obstruction already told, video orange. Brawny edema of the arm, indurated, painful, non-pitting, occurs in fixed nodes in the axilla. Elephantiasis chirurgens after radical mastectomy or radiotherapy of axilla. Cancer incurage, already I have told, seen in local adenocarcinoma carcinoma breast. Skin of chest wall is studded with the hard fixed nodules like armor coat. I have shown these photos earlier. Armor coat. Lymphangiosarcoma after radical mastectomy or MRM is Stewart-Travis syndrome. This is again MCQ question. Stewart-Travis, what is Stewart-Travis syndrome? It is a lymphangiosarcoma after radical mastectomy. Maybe after 5 years, 10 years, 15 years it develops. So these are the different effects of the lymphatic obstruction in case of carcinoma breast. See that? See the carcinoma breast with the edema on the left upper limb. See the edema here. See the axillary tail of the spence. Axillary lymph nodes are there. Lymph nodes, axillary tail of the spence. Malignancy in the axillary tail. See that? This is the tail actually. This is the deep fascia, deeper to the deep fascia. Whereas most other breast is main part of the breast tissue in the superficial fascia, outer to the deep fascia actually. So this is the axillary tail of the spence is the deep to the deep fascia. Remember. So next is having discussed about the cutaneous deeper plane and lymphatic spread. Next is again a very important thing is hematogenous spread. See, bone most common person. 70% of blood spread occurs in the bone, and again in that vertebra is a much still more common, vertebra and pelvis. Then of course femur, ends of long zone, thoracic vertebra, ribs, skull and nodal. They are osteolytic lesion, often with pathological fracture. Occasionally can be both osteolytic and osteoblastic. Occasionally can be both, but mainly they are osteolytic. Present with painful, tender, hard, non-mobile swelling with the disability. So that is what happens when it occurs. Then they will have disability. 70% recognize the bone in human are due to carcinoma breast. Again, same thing. Remember, 70% is the carcinoma breast. Spine secondary can cause severe back pain and paraplegia. MRI is diagnostic. Radiosonography bone scan should be done to assess the entire skeletal system. PET CT can also useful in these situations. Liver either through blood, occasionally through translymphatic spread. Through the blood naturally, through the here inner lower quadrant, lymphatics are communicating into the peritoneal lymphatics across the transylamic spread, across the diaphragm. So that can cause spread into the liver and peritoneum studs. In young females may cause cucumber tumor. Secondaries in the both ovaries. Lung causes malignant proliferation and cannonball secondaries. Brain causes increased intracranial pressure and coning. Adrenals and ovaries can get involved. So these are the different aspects of the spread actually. Skin, deeper plane and lymphatic and all are important. All four are important. Nothing like which is important, which is not important. Everything is important. You can see the pathological fracture here with the secondary in the carcinoma breast. Intramedullary nailing is treatment for pathological fracture, not every patient, but some patients. Carcinoma breast with rib secondaries, you can see that rib secondaries is the primary tumor, already came with advanced thing. It's a locally advanced carcinoma, see that secondaries are here. Basically, it may be systemic disease also. It's a very aggressive tumor with the locally advanced carcinoma again you have to take a biopsy and then do a palliative mastectomy, then go for chemotherapy. See that second is the ischium, second is the pubis here. Second is see the osteolytic radius. Cancer cutaneous secondary, see that one here. These cutaneous secondaries are very, very important. You can do FNAC and confirm it because already you had histological diagnosis by true cut earlier. So just to confirm that it is a malignancy, you don't require to have a detail of that. That's why FNAC is sufficient. You have to do FNAC and confirm. So very, very clearly obvious that skin is involved. Now again you have to do ultrasound, CT chest, CT abdomen, because if it still it is our patients still it is then you have to give the chemotherapy in this patient. And rather advanced, it is actually a indicator of metastatic disease, maybe having spread in the bone, spine, brain, lungs, liver and so on. So this is not just a cutaneous secondary, maybe it's a metastatic disease, is an indicator of involvement of other organ maybe. So we have to evaluate for those things. So transgenomic spread is a very important thing. Again, through mediastinal lymph nodes, it may spread into peritoneal cavity, causing secondaries in the liver, peritoneum, ovary. Quickenberg secondaries they are called as, because ovary, it is initially said that, or earlier said, still holds good in many aspects. It is said to occur in menstruating age group. There is a raw area ovary, so malignant cell transgenomic wise spreads into the peritoneal cavity. From there, these cells spill over to the raw area during ovulation time and causes secondaries in the both ovaries as a metastatic disease. They are called Quickenberg tumor. It is also observed in carcinoma stomach and so on. This is due to transgenomic spread, remember, transgenomic spread. So, having discussed about the spread, I have discussed about the spread to the skin, spread to the deeper plane, spread through lymphatics, permeation, embolization, retrograde, a different node involvement, opposite side, that is everything. Then hematogenous spread to the bone, it is already told, bone is the important area, then other organs also important. Then transgenomic spread, I said Quickenberg tumor. Spine may get involved by Batson's vertebral venous plexus because their walls are not there. So to the third posterior or other second, third, fourth, mainly third posterior intercostal vein, which is directly connected to the breast. Actually, breast drains into that. Through that, Batson plexus communicate into the posterior intercostal vein. That's why through that it goes and cell probably in the embolic way, malignant cells enter the spine and cause secondaries in the lumbar spine, pelvis and so on. So that is the presentation, hematogenous spread, I said. So all these type. Now how they present with actually. Lump in the breast, which is hard, painless, most common. At least a tumor should become 1 centimeter clinically palpable. Nipple discharge, ulceration, fungation, axillary node involvement, supraclavicular lymph node. They are hard, indiscrete initially. Eventually they are adherent to each other. Eventually fixate actually. Later forms ulceration, fungation, sinus and so on. Also spread to the supraclavicular lymph node. Chest pain hematology suggests that there is a lung secondaries. Bone pain, tenderness, pathological fracture can occur. Bone pain, tenderness, very important. Pleural effusion, ascites, chest involvement. Liver secondaries, secondary ovarian tumor, Quickenberg tumor. Pain in the breast in 10% of cases. Just mastalgia they will say. No mass is felt. That is in 10% cases can occur. That is the presentation. So lump is the most important presentation, remember. Then of nipple discharge, ulceration, fungation, depending on the stage it is, axillary node, supraclavicular node, all those things, whatever you examine, bone pain, spine pain, everything I have discussed how to look for in while discussing about the examination of the breast lump passage in clinical discussion earlier actually. So you can see the breast lump here. That is the commonest presentation. Remember, lump is the commonest presentation for carcinoma breast. Bloody discharge, you can see bloody discharge. This is the lump. Upper outer quadrant is the commonest site. Remember, this is the common site, upper outer quadrant, because the bulk of the breast tissue is in the upper outer quadrant. That is the reason. Now, having discussed about this carcinoma breast presentation and types, everything, we'll discuss a few words about the recurrent carcinoma breast. You have to know, because patient has undergone surgery, treatment, everything. After few months or years, they come with the local recurrence. They call recurrent carcinoma of the breast. It is recurrence of breast cancer after initial curative therapy. Recurrence can occur months or years after initial therapy. It can occur late also, but usually recurrence can be local or metastatic recurrence. Local recurrence in the area. If there is a right side mastectomy done, then skin nodules develop, ulcer, scar nodule develop, ulceration occurs. Ulceration can occur in the axilla also. So another recurrence is metastatic disease recurrence. It may occur at the same original site, local recurrence, this is called, or elsewhere in the body at distant site, distant recurrence. This is what it is said, distant recurrence. Local recurrence, distant, the word is important. Local recurrence, whatever I have explained, the same thing it means. In the local recurrence, a lump or ulceration nodules which are hard, fixed and can appear at the local site. If patient undergone a fresh conservative surgery, then nipple discharge, destruction of the nipple complex. So if it is after breast conservative surgery, nipple complex will get destructed and recurrence occurs there because of the destruction there in breast conservative surgery. Then further other quadrants also get involved. So we may have to do a modified radical mastectomy in this patient eventually. If it is patient undergone already mastectomy earlier, then scar nodules appears. Very typical it is, hard, skin is adherent to this one. And if you do FNEC, you are conclusive. That is sufficient actually, because already you got a histological grading, staging, receptor status, everything you know. You should do FNEC and confirm that they are metastatic disease. So there is no need to do true cut biopsy in such patient. FNEC is sufficient. Recurrence can also occur at axillary or neck nodes. Neck nodes are as palpable, hard, often fixed and fungating mass. So here also fungation can occur. Neck also it can occur. Distant recurrence, so I already told, local recurrence, distant recurrence. Distant recurrences are features of metastatic disease in the bone, lungs, liver and brain. It is evaluated by true cut biopsy from local area, FNS of the nodes, CT chest, MRI brain, isotopone scan and PET scan. So all these things should be done. And PET scan is very, very useful in this patient now. Once you do PET scan, there is no need to do additional CT scan, everything shows. PET CT scan you do, not just PET CT scan, PET CT scan together, they usually do together. PET CT scan together. That is sufficient. Positron emission tomography with the CT, of course. Treatment differs in individual patient depending on the type and site of recurrence, wide localization, nodal recurrence, nodal clearance, RT, chemotherapy, hormone therapy, immunotherapy. So all those things, newer methods are available, same. Resurgery, nodal clearance, RT, chemotherapy, hormone therapy, immunotherapy, recurrence carcinoma carries poor prognosis. Already it is treated and recurred. Naturally it carries poor prognosis. So recurrent carcinoma breast in this area, see that there is a recurrent nodule here. Local recurrence, nodule, not nipple area. Local recurrence nodule after 2 years of surgery. Now risk factors for recurrence are tumor size, spread, stage, histologic, nuclear grade, receptor status. So what are the risk factors for recurrence? What is the tumor earlier? What is the size important? What is the spread important? Stage is important. Axillary lymph node assessment and to the staging. And receptor status, ER positive, negative, PR positive, negative, then HER2 positive, negative, then so all the things are important to say which are the receptor status. So recurrent, you can see the recurrent carcinoma breast, you can see the recurrent carcinoma breast, probably she has undergone radiotherapy also. Now bilateral breast cancer, remember it is 2% common. Now there are two things you have to remember in bilateral breast cancer. One, patient has had breast cancer one side, right side suppose, and this is spread from this side to opposite side. That is also considered as a bilateral, but actually it is different entity. It is spread metastatic disease actually from the other side, maybe through dermal lymphatics or maybe through internal memory to the one side, to the other side, to the retrograde spread, to the next opposite axial line breast as a retrograde spread. Actual bilateral breast cancer is around 2 to 5% common, and there are de novo cancers. If there is a disease both sides, disease separate. De novo different cancers. Their histological type is different, histological grading is different. Whereas if it is spread from one side to other, at a metastatic disease, their grading and histological patterns are same. whereas you are grading totally different, then you have to say it is bilateral breast cancer. So that is the entity you have to remember. It is separate primary breast cancer on the opposite side in a patient who is having treated or treated for epithelial breast cancer. Incidence is 4 to 20%. It can be synchronous metachronous. There is a 5-fold increase in the second breast cancer on opposite side in a female who has had breast cancer on one side. Lobular carcinoma in situ, multifocal breast cancer, family history are risk factors. Remember, this is a risk factor. It may terminate invasive breast cancer both sides. Lobular carcinomas are bilateral commonly, and so naturally one side it is there, other side it's a risk factor. Multifocal breast cancers, family history are the risk factors. It is investigated like any breast cancer, staged accordingly and treated. Right side staged separately, left side staged separately. Same way you have to do the investigation. If a tumor on the opposite side metastatic, then it will show separate histology and differentiation with the mammography, showing less infiltrative, diffuse, without microcalcification but with edema. Note, if it is metastatic, it is stage 4 disease. Understood? So this is primary de novo malignancy is different, one side to other side different. So primary de novo stage accordingly. Maybe right side stage 1, left side stage 2, like that. Whereas if it is spread from this side, automatically stage 4 disease, metastatic disease actually. So that is what I meant actually here. So there is a criteria called Chowdhury-Millis criteria. Or not Mills, it is Millis. 2%. Chowdhury-Millis criteria help to differentiate primary contralateral breast cancer from metastatic. That's in situ change, different histological pattern, different differentiation in the opposite breast. Clinically or by evaluation, epithelial tumors have not shown any by features of spread. So this is right side stage 1 clinically, then you can't say opposite side is this one. So this is the clinical criteria, histological in situ changes. And histological pattern, this is the most important thing. Histological pattern and differentiation. If both are differentiated and both are so different, then it is not the metastasis on the opposite side. It's a two independent malignancy in two beds. So that is the Chowdhury-Millis criteria, important thing. So the bilateral breast cancer already operated. So again bilateral breast cancer, remember, see. So Chowdhury-Millis criteria is the most important criteria to say that both breast malignancy, there are independent malignancies. So stage it according, right side and separate, because the differentiation and patterns are different. Because if differentiation and patterns are same, that means it metastasis from one side to other, that may go to the stage 4 disease. This is what I meant, is very, very important. Now having discussed about that, now we will discuss the staging system. There are TNM staging, the currently edition is the 2018 AGC's 8th edition staging. It is one used. Now currently in the breast, there is a molecular staging also, that is becoming more important based on the receptor status. So always you have to study the receptor status in all tissue. That's why true cut biopsy becomes the more important ideal than FNAC, and so molecular staging is important. That also we will discuss after discussing about the TNM staging. TX is primary tumor cannot be assessed, already treated elsewhere without documentation. T0 no evidence of primary. TS carcinoma in situ. TIS is the ductal carcinoma in situ. TIS Paget disease of the nipple, not as if the invasive carcinoma or with the disease. Tumor T1 is important. Tumor less than 2 centimeter. T1 MI micro invasion 1 millimeter or less in greater dimension. T1A 1 to 5 millimeter. 1B 5. That's what it is divided now. Up to 2 centimeter divided. 5 millimeter, 10 millimeter, 20 millimeter. T1 ABC. So T2 is 2 to 5 centimeter or greater dimension. T3 is more than 5 centimeter dimension. Any size with the direct extension to the chest wall or skin or both. So T1 less than 2 centimeter, T2 2 to 5 centimeter, T3 more than 5 centimeter. Very easy to remember. And in the T1 is divided to A, B, C depending on the 5 millimeter, 10 millimeter, 20 millimeter. Now T4 is any size with direct extension to chest wall or skin or both. T4A is a tumor of any size extending to the chest wall. See, A is the chest wall, petrol comes first, skin comes later. Not including only pectoralis muscle invasion reduction. Chest wall means the ribs, intercostal muscles, serratus anterior, but not pectoral muscles. So chest wall includes serratus anterior, intercostal muscles, and ribs. And 4B is ulceration or epithelial satellite nodules or edema, including the purity orange of the skin, which do not meet the criteria of inflammatory carcinoma of the rest. If there are no criteria of inflammatory carcinoma, skin involvement is there, then becomes 4B. Chest wall involvement 4A, skin involvement 4B.
4C is a combination of 4A and B. Both chest wall and skin is involved. And 4D is specific inflammatory carcinoma. So inflammatory carcinoma is always advanced, always local advanced, always stage 3. There is no stage 1 inflammatory carcinoma, there is no stage 2 inflammatory carcinoma. Remember, always stage 3. It is a T4D, it is always it is a 4D. So 4A is the chest wall, 4B is the skin, 4C is a combination of A and B, 4D is inflammatory carcinoma of the breast. That is how it is classified. TNM classification, T1 less than 2 cm, T2 2 to 5 cm, T3 is more than 5 cm, T4 is involvement of all these things. So regional lymph nodes cannot be assessed. N0 is those nodes are involved. N1 is metastasis mobile, ipsilateral level 1 and 2 lymph nodes. These levels are called burst levels below the petrous minor and behind the petrous minor 1 and 2. N2A metastasis ipsilateral level 1 and 2 nodes which are fixed to another or other structures. N2B is metastasis only in clinical detected ipsilateral internal memory nodes. Internal memory it is. And in the absence of clinical evident level 1 and 2 lymph nodes. So only internal memory nodes, so no axillary nodes, then becomes level 2B. N3A is metastasis ipsilateral infraclavicular lymph nodes here. Infraclavicular lymph node level 3 axillary with or without level 1 and 2 axillary lymph node involvement. Only this infraclavicular lymph node or Hallstatt lymph node or subclavicular lymph nodes are involved without axillary lymph node involvement. That is called as stage 3A. Stage 3B is metastasis ipsilateral internal membrane lymph node with clinical evident level 1 and 2 axillary lymph node involvement. So only this one is still 3A, but infraclavicular level only, and 3B is involvement of the internal membrane nodes with the level in axillary lymph node. 3C is ipsilateral infraclavicular nodes with or without axillary internal membrane nodes involvement. It is 3C. Ipsilateral supraclavicular lymph nodes. This is stage 3A is infraclavicular, stage 3A. Stage 3B is into the memory here. Stage 3C is supraclavicular. That's what you have to remember. 3A, 3B, 3C. 3A, 3A, 3B, 3C. 3A here, 3A here. 3A, 3B, 3C. This is what you have to remember. Internal, this is infraclavicular, parasternal or internal memory nodes, infraclavicular, internal memory nodes, supraclavicular nodes. Infraclavicular, internal memory, supraclavicular. That's what you have to remember. N3A, B, C. Very easy to remember that. Distant metastasis, M is a distant metastasis, M0, no clinical radiological evidence of distant metastasis, no clinical or radiological evidence of distant spread metastasis, but deficits or deficits of molecularly or microscopically detected tumor cells in circulating blood. CM0 I1, it is bone marrow or other regional lymph node, other regional nodal tissue that are no larger than 0.2 mm in a patient without symptoms or signs of metastasis. This is very important. No clinical or radiological evidence of distant spread metastasis, but deficits of molecularly or microscopically detected tumor cells in circulating blood. Circulating distant spread is not there, but circulating blood is showing positive for malignant cells. Bone marrow, other nodal lymph nodes are that are no longer than larger than 0.2 mm in a patient without symptoms. So nodal spread. Remember, regional node, other non-regional nodal spread. Remember, non-regional nodal spread with showing the tumor cells in circulating blood less than 0.2 mm again comes under CM0I1. Non-nodal spread in the circulating blood, important, less than 0.2 mm. M1 distant detectable metastasis as determined by classical clinical and radiographic means and are histologically proven larger than 0.2 mm. So CM0 is less than 0.2 mm. CM1 is more than 0.2 mm. CM0 also involves microscopically distant spread, but deposits of molecularly microscopically detected tumor cells in the circulating blood or bone marrow. Less than 0.2 mm CM0 I1. More than 0.2 mm becomes M1. So this is what you have to remember. This is very, very important. So stage group I am not going to detail that. 0, 1A, 1B, 2A. Up to 2A it becomes early breast cancer. To 2A it becomes early breast cancer. From 2B onwards it is this one late, and 3A anyway 3A, 3B is locally advanced carcinoma breast. Like that it is being classified. So MX is removed in current edition DNM staging. C stage is given by clinical patient patient. P stage is given by pathological examination of surgical specimen. Y stage assessed after chemotherapy and or radiation therapy. In other words, the individual had neoadjuvant therapy. R stage is for recurrent tumor in an individual that had some time from period of time free from disease as such. So clinically detected is defined as detected by imaging studies excluding lymphocytography or by clinical examination and having characteristic highly suspicious of malignancy or a presumed pathological micrometastasis based on the fine needle aspiration biopsy with the cytological examination. That is the meaning of clinically detected. Means detected by imaging or by clinical examination or by pathological micrometastasis based on the FNAC or cytological. FNAC, clinical and pathological micrometastasis. This is how we will say that it's clinically detected tumor. Confirmation of clinically detected metastasis disease by fine needle aspiration without excision biopsy is designated as F. If you do FNAC and confirm it, metastasis, clinically detected metastasis disease. Lobular carcinoma is a benign entity and is removed from TNM staging in HCC cancer staging manual 8th edition. Earlier it was considered as a malignant but in situ one, but it is considered as a potentially malignant condition and so removed from the staging as such. T1 include T1 MI. T0, T1 with nodal micrometastasis are excluded from stage 2A and is classified as stage 1B. That is the changes actually. If patient present with the M1 prior to neoadjuvant systemic therapy, the stage is considered as stage 4 and will remain stage 4 regardless of response to the neoadjuvant therapy. So if there is a spread actually, then it is always stage 4 and after treatment you don't call it a stage 3 at all. You won't be able to downstage the metastatic disease actually, don't do that. It's not accepted. Isolated tumor cluster is cluster of tumor cells wherein each cluster less than 0.2 millimeter size. So that is isolated tumor cluster. A cluster of tumor cells wherein each cluster is less than 0.2 millimeter in size. So cluster less than 0.2 millimeter. That is called isolated tumor cluster. It's very, very important definition. May not ask in the Viva or anything. That's for your memory purpose. It may be remember less than 0.2 millimeter. Micrometastasis is deposit tumor less than 2 millimeter in size. Macro is more than. This is definition. Remember, micro is less than 2 millimeter. Macro is histologically macro is more than 2 millimeter. Circulating tumor cells are assessed using 7.5 ml of blood through cell tracks analyzer 2 with the DNA stain DAPI. More than 1 cell per 7.5 ml for primary tumor and more than 5 cells per 7.5 ml for metastatic disease is considered as unfavorable. So all these things are, I'll say, unfavorable. DAPI more than 1 cells per 75 ml primary tumor or more than 5 cells per 75 ml metastatic disease is considered as unfavorable. Disseminated tumor cells. So there are two things you have to remember: circulating tumor cells, disseminated tumor cells. In bone marrow are assessed by liquid biopsy from bone marrow. 1 cell or more is unfavorable. So disseminated tumor cells also numbers are 1 or more also are always unfavorable. Now I already told while discussing the TNM staging that is TNM staging is very easier because all malignancy TNM staging is there. Now for carcinoma breast it is very specific that molecular subtypes carcinoma breast. That is more important for planning the chemotherapy or oncological management, adjuvant therapy rather. So that is important. That's why ER status, PR status, HER2 new status, KS67 status has to be assessed in all these patients, and so that stage molecular weight in these patients always. That is the more important thing. The first one is basal like, it is 15-25%. It's a ER negative, PR negative, HER2 negative, also called the triple negative breast cancer. It is often asked as a short note or MCQ question, remember, very short, small short note. Most BRC and breast cancers are basal like, triple negative breast cancer. They are high grade, aggressive with poor prognosis, common in black and young individuals, high incidence of lung and brain secondaries. That is a very important type. Triple negative is a very, very aggressive malignancy, remember. Luminal A is 50% common. So common is luminal A, this is 25%. ER positive, HER2 negative and low grade. They are low grade, they are high grade. They are slow growing and occur in postmenopausal women. They respond well to hormone therapy. Luminal B is 15-20%. ER positive, PR positive, HER2 positive, triple positive it is. One is triple negative, one is AR positive, HER2 negative, here it is all are positive, but often high grade it can be. They respond to chemotherapy well. HER2 rich is 10%, AR negative, poorly differentiated, aggressive with high incidence of brain secondaries. In this brain secondary is common. Treated with chemotherapy and trastuzumab. Lapatinib is used if brain metastases are present, as trastuzumab will not cross the blood-brain barrier. So in such patient you have to use the lapatinib, where it crosses the blood-brain barrier, whereas trastuzumab will not cross the blood-brain barrier. So trastuzumab is not useful here in order to reach. All other type it is quite useful, very commonly now available, but costly it is. Those are decided by the oncologist depending on the grade, type, size, everything. So trastuzumab is a very good drug actually. Trastuzumab will not cross the blood-brain barrier. That is important. That is why lapatinib is used in those patients with the brain mets. Now next is normal breast, like 5% ER positive, HER2 negative, luminal AR positive, recently identified androgen responsive subtype. AR is androgen responsive. It's a new one again. ER you know, PR you know, HER2 new you know, Ki67 you know. Now AR type is there, androgen responsive subtype, which may respond to anti-hormonal treatment with bicalutamide. So that is again this is the one new one, androgen responsive subtype. BB2 HER2 has amplified HER2 new actually. HER2 new, we know that human receptor epidermal growth factor receptor neurophilin 2, that is the full name actually. Claudin low is more recently discovered class, often triple negative, but distinct in that there is low expression of cell-cell junction proteins including E-cadherin, and frequently there is infiltration with the lymphocytes. So that is the molecular subtype, whatever I have discussed. There is the current staging, current molecular classification is used, which is very important to manage these patients. Now genomic profile and scores, DNA microarray, gene analysis. Gene analysis can be used in malignancy, but it's more often used for carcinoma breast. That's why I have discussed here genomic profile, gene analysis. Maybe it's a very short note, so difficult to understand. I'll just mention what exactly it is. Genomic tests analyze as sample of a cancer tumor to see how active certain genes are. The activity level of these genes affect the behavior of the cancer, including how likely it is to grow and spread. Breast cancer index, it is used to predict the risk of node negative, hormone receptor positive breast cancer patients coming back 5 to 10 years after diagnosis. EndoPredict is a gene expression, numerical scores from 0 to 15, up to 5 is low risk, more than 5 is. All this, there are scores actually. So MAMA-print is very commonly used now. It's available in many centers. 70 genes are assessed to predict breast cancer recurrence. Less than 10% is low risk for recurrence in 10 years. Oncotype DX, 20, this may be asked as the MCQ question. MAMA-print, how many genes are there? 70 genes. And less than 10% is low risk. Oncotype DX, 21 genes are assessed. These numbers may be useful mainly for theory. They may not ask. Why also they won't ask, but MCQ they may ask, remember. Oncotype DX, 21 genes are assessed, 16 cancer-related and 5 normal genes. It is assessed by RT-PCR using tissue paraffin section. Score less than 11 yields very low risk for recurrence. So this is very useful for to see the recurrence. MAMA-print also very useful. PAM50 gene signature, pro-sigma is called genomic test. It creates score from 0 to 100 for prediction of distant recurrence. 50 genes are assessed. It is categorized in node negative patients as low up to 50, intermediate 41 to 60, high 60 to 100. In node positive patient, it is a low 0 to 40, high 41 to 100. There is no intermediate in node positive patient. It is performed on RNA isolated from FFPE breast tumor tissue. It measures the expression levels of 50 genes. So 50 genes are assessed here. This very number assessment. There's a 50 gene PAM 50 gene signature has come. Pro sigma it is. Pro sigma. So all these different are the genomic subtyping of the carcinoma breast. It is often maybe as a short note, very difficult to remember, but newer things are coming up. Androgen related markers also coming up, other than ERPR, HER2 new, Ki67. So this is just mentioning what are newer things have come up. Exam may not ask actually. So having discussed about the AJCC staging, molecular types, then genomic types. So AJCC, molecular, genomic, AJCC, molecular, genomic. That is a classification. Just remember yourself. For recapitulation, mainly AJCC you have to remember. Then luminal A, luminal B, basal type, then all those things, different types which you have to just remember the names which may be asked. And yeah, that numbers 50, 10, all those things, that those numbers you have to remember, because MCQ they may ask. Theory, why they may won't be asked, don't ask that much detail actually. They're difficult to remember also and recapitulate unless you are writing for MCQs. Now what are the, having said that this is carcinoma breast, always it is you have to keep in mind that there are differential diagnoses. All those things which I have discussed in earlier sessions, benign disease of the breast, they are called as differential diagnosis for breast. So I'll repeat, all these things are discussed: fibroadenosis, traumatic fatty necrosis, tuberculosis of the breast, blood good stage, filariasis, mastitis, antibioma, galactosil, Mandor disease, phylloides, fibroadenoma. Fibroadenoma, also called as ANDI, part of ANDI. Fibroadenosis, fibroadenoma, sclerosing adenosis are the part of the ANDI. So all these things are the differential diagnosis. Remember, blood good stage, tuberculosis, traumatic fatty, mastitis, antibioma, Mandor disease, galactosil, cytocircumphyllosis, serocytic disease of the Brody actually. Both are same. All the things are the differential diagnosis for carcinoma breast. You have to remember it, because maybe a short note sometimes, many times they will ask, enumerate 8 differential diagnoses for carcinoma breast. You should be able to enumerate all these things. Enumerate 4, just small portion. Enumerate just 3, that's 2 differential diagnoses. Important differential diagnoses you have to mention: traumatic fatty necrosis, mastitis, then blood good cyst, antibioma, galactosil, all those things. Rare thing is okay. What they will ask when you present a carcinoma breast, what are the differential diagnoses? You have to remember, even though you are sure that carcinoma breast, you should keep something in mind as a differential diagnosis for carcinoma breast. So that's what this slide mentions. So you have discussed about the pathology, you also discussed about the spread, that is a cutaneous spread, a deeper plane spread, the lymphatic spread, hematogenous spread. You also mainly spine is not to the Batson breast we have discussed. After that we have discussed the AJCC staging, molecular staging, genomic typing, and differential diagnosis. So students, I hope you have understood the session very well. Thank you very much.